My task, once I get started, is to sort of give you an overview and an update on, there we go, T1 bladder cancer. So these are my disclosures. I do a fair amount of consulting for a variety of companies who are working largely in the non-muscle invasive space, and we've generated some clinical trials out of SWOG, and we have funding that comes through the NCI, not directly from Genentech and JBL. And I'll reference some of that as we go through the talk. This is what I'll cover. Mike kind of set up part of my talk quite well regarding the importance of re-TUR and risk stratification. So I'll emphasize some of those points as we go along. Okay, so one of the things that Mike alluded to is that it's very rare, and if you get a report back that says T1 low grade, I wouldn't trust it. I'd go back and talk to your pathologist, go look at it under the microscope. I too have seen a handful of these, but they're very rare events. So for the most part, T1 is high grade. About 30% of patients have associated carcinoma in situ, and there's a very high risk category of multifocal large volume, particularly recurrent and associated with CIS and some of the variant histology and prostatic urethra involvement. Those patients probably ought to be treated with an upfront cystectomy. There's been a ton of work on T1 substaging. So you're aware that the lamina propria has blood vessels in it. It's got muscularis mucosa in it, and the concept is that more deep invasion of the lamina propria is associated with a worse prognosis than superficial involvement of the lamina propria. And then you absolutely have to have detrusor muscle in the specimen in order to accurately stage a high-grade T1 cancer. If you don't have it, it's okay. You're going to need to go back and do a re-resection, and re-resection is a standard of care regardless, even if you have muscle in, and re-resection is required in all patients, although I'm going to show you some newer data that suggests that that may not necessarily be the case. Next slide, please. If you have associated CIS with a high-grade T1 tumor, and then remember, you have to look for this. So enhanced cystoscopy, we'll hear about that a bit later, can help you identify patients with occult CIS. And then doing site-directed biopsies of normal appearing mucosa adjacent and remote will help identify those patients with CIS, and it's a very clear driver of outcome and can influence decision-making. And this is a cystectomy series that shows that. This is just a bit on substaging, and these are some data, very nice work from Amsterdam, Bas van Rijn and his group, showing the importance of a more sort of deeply invasive T1 tumor into the lamina propria and the worst outcome associated with that. So let's do a little case, 57-year-old. This is a patient, this is a real patient, I'm not making this up, who came to me. He'd had a T1 high-grade tumor, multifocal CIS, so he's high risk. And the urologist had offered both cystectomy and BCG without re-resection. And I told him, I said, sorry, that's a non-starter. So I took him back and did a re-resection, and big surprise, he's got a muscle-invasive bladder cancer. So I can't tell you, and I'm sure Sanjay and Mike would back me up on this, how many times, and of course no one in this audience would do that, but urologists skip this step, and when you skip this step, trouble awaits. On the flip side, when you do a re-resection, there's no residual T1 disease, for instance, you can have a lot of confidence in going ahead with BCG and with a higher probability of a good outcome. Fortunately, he got neoadjuvant chemotherapy and a cystectomy, and he's done fine now, about 18 months post-op. Here's some data that was published in 2016 that shows the outcome with and without re-TUR. You can see the data in the inset in the bottom of the Kaplan-Meier plot, but there's a highly statistically significant difference in outcome just simply stratifying by the single covariate of whether or not there was a re-resection. Michael already showed you this. This is really the only randomized trial I'm aware of. I don't think that we would do a randomized trial today without re-TUR, but it clearly shows in it's sort of almost level one evidence. There's some issues with how this trial was conducted, but it shows the importance of the second TUR, the re-TUR in outcome. You see that on the right. And there's another plot there, and it also has an impact on progression. So you see the impact on recurrence and progression. If you need any further convincing, I hope you don't need any further convincing. It's in all of our guidelines. They're very consistent with the importance of re-TUR. This is a cystectomy series. It's quoted quite a bit, but you can see that it's got a 2001 publication date. And you could argue that maybe the patients coming into this, while yes, they were clinically staged T1, maybe they weren't restaged, maybe they didn't have a re-TUR, but regardless, the absence of muscle had a profound impact on understaging. And again, this is nice data from Guido Dalbagni, a series from Harry Herb, Memorial Sloan Kettering, 2009, also a bit older, that shows the restaging when you have T1 in the restaging specimen, the adverse impact on outcome. And so when you do a re-TUR and you still have T1 disease, that's a signal that maybe that patient you need to have a conversation about going ahead with radical cystectomy if they're otherwise medically fit and accepting of a major operation. This is one study that shows the impact of understaging. So again, a cystectomy series, multi-center, and you can see that patients who were pathologically upstaged either by T-stage or end-stage or both had a profoundly worse impact, worse outcome regarding cancer-specific survival. Our goal, the imperative that we have as urologists is to, I'll use a sort of a phrase of pull the trigger, so to speak, on radical cystectomy, what some people refer to as early cystectomy. I think a lot of us would just say appropriate timing for radical cystectomy. I'm fond of saying that radical cystectomy, this is to the medical oncologist in the audience, getting Dan to perk up there, that the complete response rate to a radical cystectomy is 100%. Right? When they wake up, they're disease-free. There's no drug that provides that. BCG certainly doesn't provide that. Obviously, it's not durable because a lot of those patients relapse afterwards, but it's a good tool. It's a good surgical tool for appropriately selected patients who have high-risk, non-muscle invasive disease. And the challenge for us is to recognize who those high-risk patients are and to intervene early. So this is some data. So if you listen to Joan Palu is one of the leading authorities in Europe. He's from Barcelona. He's done a huge amount of work in this space. And this was a multi-center conglomerate from primarily Europe. And they asked a question about re-TUR with or without muscle in the specimen. And you can advance through each of these Kaplan-Meier plots and you're going to see that there's no difference. Time to progression and duration of survival. And so their claim in a contemporary sort of arena is that the dogma of every single patient with a T1 high grade needs a re-TUR, they're beginning to rethink this. The Europeans are starting to look again at their guidelines. There may be some revisions. The way I approach this is when I'm teaching trainees, it's like everybody gets a re-TUR. Because it's sort of like everybody comes into your office, gets a urinalysis. It's simple. But there are some nuances here. So for instance, perhaps the patient with a 2 or 3 centimeter T1 high grade, first occurrence, good muscle, I got it all, did some biopsies. Does every single patient like that need to go back to the OR? Probably not. But I think until we have better data and more data suggesting the safety of that, and perhaps your own personal experience, the fallback is re-TUR. But this is a paper that's worth taking a look at that's sort of reanalyzing this dogma, for lack of a better term. So these are patients who are highest risk, and I think most of us would recommend a cystectomy up front. Certainly the patient who progresses to a T1 from a non-muscle invasive disease, muscle invasive cancer, that's a BCG unresponsive patient. I'll show you that in just a second. Large volume, multifocal, persistent T1 high grade on re-resection. Lymphovascular invasion does occur. About 7 to 10% of patients can occur, even though it's just in the lamina propria. And as Mike pointed out, patients with variant histology, particularly micropapillary. These are the unfavorable variant histologies, micropapillary. I think small cell non-muscle invasive would be quite uncommon. But if it does occur, these patients progress very early. They need upfront chemotherapy and then radical cystectomy. So this is a meta-analysis of high-grade, multiple series of high-grade T1 tumors, and you can see I've highlighted depth of invasion being a very important prognostic variable for understaging, and then you have lymphovascular invasions, CIS, larger tumors, older age. Again, putting the body of evidence together, I think that we're pretty good today at identifying the highest risk patients. We are going to be seeing more and more about molecular staging. This is the group from Lund has probably been working on this area using transcriptomics for the longest. And they were able to risk stratify high-grade T1 patients based upon a number of different markers, and they did unsupervised clustering. You can see that on the top left, and you can see on the bottom right how the three so-called subtypes that they identified were associated with the outcome measure of progression-free survival. So more to come on this. It's not ready for clinical use, but we certainly are learning quite a bit about the molecular genetics of non-muscle invasive disease as well as muscle invasive disease. These are the guidelines for initial cystectomy. I think they're fairly consistent between the AUA and the EUA. And another, I like to emphasize this, sort of the danger of waiting to pull the trigger on a radical cystectomy until there's bona fide evidence of muscle invasive disease. You can see the Kaplan-Meier plot on the right. That's what deferred cystectomy is referring to. And you take a pretty significant hit on the probability of survival long term. And I just want to emphasize that if you have a PT1 or less N0 pathology on a radical cystectomy, the patient never had muscle invasive disease, their outcomes are actually quite good. Another case, 64-year-old lady, 3-centimeter tumor, completely resected, T1 high grade, muscle in the specimen, re-resection, no residual cancer, no CIS. What's the next step? This is not a question for the audience response system, but I think it's pretty obvious. Go ahead and advance it. This is a patient who would be perfect for intravesical immunotherapy with BCG. These are the guidelines for BCG. These are, by definition, high-risk patients. They need induction plus 3 years of maintenance. And this is just the SWOG trial that established that as a standard of care. And you can see a highly statistically significant difference on recurrence on the left and a surrogate marker for progression-free survival on the right. Nailing the status of the bladder as precisely as possible at the 3-month mark, so that's 6 weeks after completing induction, is imperative. As you can see in here, this is a secondary analysis of 8507 patients who had a CR at 3 months have a much better outcome than those who did not. So we have to precisely stage those patients at that time point. Another case, now a patient who has a recurrent high-grade T1 tumor with CIS. And the best treatment option for this is a radical cystectomy. So recurrence of high-grade T1 after a full course of BCG is a red flag. So these are the guideline recommendations for recurrence of T1 high-grade. Cystectomy is consistent across the guidelines. And this is the definition of BCG unresponsive. It's newer terminology that essentially recapitulates what we've used to call BCG refractory disease. And if you have a recurrent high-grade T1 after induction only, that meets the criteria. These are off-trial options available. You can see that after BCG and interferon, they're largely chemotherapy. And these are the list of clinical trials. And I'm not going to go into the clinical trials, but this is a relatively current list. I do some of these. I have research funding for some of these and do consulting for some, so please acknowledge the conflicts. And these are the take-home messages. So thank you very much.